Thank you very much, Daniele, for really nice introduction, kind introductions. I like to thank Gary here for working with me for the past many years fighting about this. Daniele, and other group were very supportive of the idea. So now we have officially the organization. I also like to thank Dr. Gary Glasser for his participation in the textbook that we wrote together. This presentation is some collection of the book. So I need to make a statement that some of these slides are created by AI. The information is mine, but the creation of the slides are AI. Just to be clear and straightforward. So with that orofacial pain, we know that's typically dental cause is very high prevalence. We have to make sure that, first of all, we have to look at what caused the pain. Typically, we need to do 2D X-rays to start with, and then when more detailed assessment is needed, we can move to 3D imaging like CBCT or CT. Most likely, when we have some evidence that we need to do some testing or some imaging of the soft tissue, we have to move to MRIs or other soft tissue modalities. The key principle is targeted imaging, choosing the right modality based on a specific clinical question rather than using it as routine imaging. Now, in our clinics, how do we follow our patients? We take history, most of the times lengthy history. We do perform clinical examination, and we have to think about what kind of imaging we need, if we need it. We don't have to do some imaging. We don't have to expose the patient to any radiation if there is no. And sometimes we need to consider other testing, blood work, something else, ultrasounds, whatever. So we need to come up with some kind of diagnosis or differential diagnosis to this patient's problems. And then we can either plan treatment for this patient, and if we see that the issues or the problem beyond our expertise, we should not be shy from referring the patient to orofacial pain specialist, a neurologist, or other medical colleagues. So based on the finding, we can establish the diagnostic tool. We can start with panoramic or limited intraoral X-rays. And if in cases where we need more details, as I said earlier, advanced imaging like CT scan, CBCT, medical CT scan is really indicated, or we should plan on it. Now, we know that about 75% of our practice or in dental practice have dental related issues. So the practical approach is really to rule out the dental issues. And as soon as we rule out the dental issues, we have to look at some other factors, like if we concentrate on the TM joint itself, we'll have to look, is the problem hard tissue, bone tissue, so we can use CBCT. If we are looking at the disc and internal derangement or other adjacent tissue problems, we have to look at the MRI. When we talk about trigeminal neuralgia, glossopharyngeal neuralgia, or other problems, we can also consider the MRI as a first line and diagnostic tool. At this stage, we should target the problems by considering either CBCT or MRI for the TM joints and MRI for the brain, for the head, for other neuropathic or headache problems. We know sometimes for CT scan, we may consider it for headaches, like as a first line for acute headaches. I have this case, a 60-year-old Caucasian male presented to the office with pain in the left maxillary area or maxilla, including the upper first and second bicuspids. So he experienced fullness feeling in the left maxillary sinus. So we have this problem on the left side. His dentist took panoramic X-ray without significant findings. So he sent the patient to me. His history was 3 months ago, he bit on something he does not remember and started experiencing shooting pain in the premolars area, up in the sinus area. The pain was throbbing and chewing and become more aggressively mild and constant pain. He reported that he clenches his teeth. Occasionally he gets radiating pain and becomes shooting to the TM joint area. Chewing, clenching, and provokes his sharp pain. I did cone beam CT scan because he brought his panoramic and really did not help. So with the CBCT, you can get small slices. I noticed some crack in the premolars area 14, and that's really what was the problem. So the patient was sent back to his dentist, and the tooth number 14 or the second premolar was in the maxillary second molar. I know some Europeans, some other countries don't use the American numbers. And the patient was discharged. Now, evaluation of endodontic pain follows a stepwise approach. We have to start with the intraoral X-ray, panoramic X-ray. As a first line as dentist, I'm sure most of us or most of you have intraoral X-rays or panoramic X-rays. So we have to rule out caries or periapical diseases. If findings are unclear and we have more complex pathology, we should suspect something different, and we have to escalate the imaging to limited view of CBCT limited view. So the key is to begin with 2D dimensional X-ray, very safe, low radiation, and then we escalate if necessary to CBCT if needed. Now, when non-endodontic structural causes are suspected, we have to start considering other problems. Like for sinus symptoms, CT scan without contrast is preferred, but only in persistent or refractory cases. Most sinusitis is diagnosed clinically by ear, nose, and throat or otolaryngologist. In the salivary gland issues, CT scan for inflammatory process, acute cases, but when we expect cancer or suspect masses, then MRI will be the next option. So this is for the otolaryngologist. We have to avoid cialography because of if there is any infection in the salivary glands. For ear-referred pain, CT scan helps to diagnose any mastoid problems and middle ear infections. So overall, imaging here is highly targeted. As you see, I always say targeted. So it's really, that's what we have to follow when we request imaging for our patients. So it's highly targeted, driven by clinical suspicion to avoid unnecessary studies. So again, we have to really look at the patient's symptoms and decide what we need to do or what we need to order. This patient is about 50 years old, white female, presented to me with pain on the left side maxilla. I took my CBCT scan and I saw, let me use this large cyst in the left maxillary sinus. What scared me about it, we see sinuses cysts often. I saw we lost the border of the sinus wall. So these are really some signs we have to be worried about it. And other section or other slice of the cone beam CT scan. So almost the patient lost the external wall of the left maxillary sinus. When you find some kind of white bodies inside the lesion and the maxillary sinus, it's always suspicious of fungal sinusitis. So will be some growth in the sinus cavity. So I put the patient on augmentin, amoxicillin, and naproxen, and was referred to ear, nose, and throat. And the cyst was surgically removed, and it was invasive large fungal cyst. So these are really some of the important issues we have to look at when see our patients. So if you have a patient with these kind of symptoms, teeth pain, you have to ask the patient if they have any problems in the maxilla, several teeth pain, dull pain, aching and throbbing. And sometimes it's associated with the pressure. You have to palpate, apply some pressure in the sinus or zygomatic arch area in the sinus area. Patients bending down, it may aggravate the pain. And coughing and sneezing also aggravate the pain. Chewing, cold, percussion worsen the pain. If the patient or the patients have history of upper respiratory infection or nasal congestion or sinus problems. So the clinical examination, the clinical history is very important for our patients. We can shift a little bit. This patient, 9-year-old girl, came with her father to the office with panoramic X-ray from her pediatric dentist. She had pain on the right side along with limited mouth opening. Her mouth opening was very limited. She said that she fell in the playground and had fall on her face. She did not tell her parents that. I'm not sure if she was scared or something, but the panoramic X-ray that was brought by her dentist did not reveal any fractures. So the clinical examination, she was able to 15 millimeter with severe pain. Now we have this panoramic X-ray. The pain is on the right side. From first look, you see everything looks really normal. You don't see any fractures, anything to rely on. Now I did close up of the X-ray. If you look here, I always compare right to the left. This is the left side, the bone looks nice. If I go to the left side, there is some, panoramic problems here, but if you look at the border of the ramus, this area where I'm looking, again, look here, this area. So that's made me suspicious to do CBCT. Now, this is the CBCT. It showed some eroded ramus, some defect in the ramus area. Knowing the child is young, she said she took a fall a week ago, so I'm going to show you some of the views. This the axial views for the radiologist here with us, or the non-radiologist. When you see double image of the bone, and you see some loss of bone and some widening in the bone, some different layers, that mean this is very clear osteomyelitis. So the patient was referred to the infectious disease patient at the hospital, and they treated her. I don't know. I don't have any information. The parents decided not to come back because either solve the problem or there is other problems. But the question, the note here is, we have to look first at panoramic X-ray, listen to the patient history. Sometimes, you may not believe the patient what they say because they may hiding something. They are afraid to say something, especially with kids. So anyhow, so this is really this case here. Now we kind of move a little bit to the TMJ pathologies, focusing on choosing imaging based on tissue of interest. Now, the TMJ includes both hard bone, hard tissue, and soft tissue. And we cannot do one modality or single modality that is sufficient. So we may consider if the problem we know that's more hard tissue, CBCT will be really the option here. Also, if we have disc-related issue or surrounding soft tissue, we have to decide an MRI or not. So different modalities complement each other in TMJ problems and in general in orofacial pain practice. So these modalities enabling a more precise and targeted diagnosis of TMJ disorders. A practical approach to TMJ imaging is to think in terms of soft tissue versus hard tissue, as I mentioned earlier. If we are looking for disc displacement, disc problems, definitely MRI will be the best option for these patients. So we have to look at the patients, listen to their history, do the clinical examination, and decide if really the MRI is needed or not. In my practice, I usually don't do MRI of the TM joints often. I do MRI of the TM joints when my treatment fails, or I'm looking for surgical approach for these patients. So again, we have to evaluate if the MRI or CT scan needed for our patients. For hard tissue, the CT or CBCT are highly recommended, especially if you think they are more involved. I usually order CT, but most common use is the CBCT. We can assess osteophytes, erosion in the surface of the condyles, subcondylar cyst, sclerotic bone. These are really more common findings with the hard tissue imaging. So the clinical trigger is suspected degenerative joint diseases, crepitus sounds. Knowing from my experience, not always you hear crepitus sounds is arthritic changes, could be some ligaments issues. And we have to make sure that the imaging secured in your office or if you want to refer them outside. And we know panoramic X-ray is not really the modality that we use for good view of the TM joints and final diagnosis. So the sensitivity is very low with the panoramic. Sometimes we, with TMJ cases, we need more routine imaging. So for ankylosis CT or CBCT helps define bone fusion, while MRI helps with fibrous ankylosis of the TM joints. When we have suspect neoplasm, which I'll show you case, then we have to move to the use of contrast to enhance the views of the area that's expected. The goal is really assessing soft tissue, tumor extensions, adjacent area of the joints. So in orofacial pain practice, I'm sure we all get referred patients, young patients, juvenile adults, adolescents, or children for jaw pain from orthodontists, from pediatric otolaryngologist. So we have to decide what to do. We do CBCT in my practice just to get an idea, especially if they have pain, if they have crepitus sounds in the joints. Just for clarification, I do in my practice, I send the patients for blood work to rule out any autoimmune diseases. If any of the joints, if any of the results were positive for autoimmune disease like high anti-CCP or ANA, I usually send them for MRI because the MRI is the best modality to detect rheumatoid arthritis in the TM joints in their joints. I know recently in the past few years, the name changed from juvenile rheumatoid arthritis to juvenile idiopathic arthritis. So if we find some fluid, early effusion in the joints, in the bone marrow, that means really it is confirmed rheumatoid arthritis in the children. So overall, imaging should always be tailored to the suspected pathology and the tissue involved. This case, years back, a patient about 30 years old came with limited mouth opening, jaw pain on the left side. I did my CBCT. If we look at the right TM joint, the condyle looks very clean. If you look at the left joint, you see the cortical bone is a little bit off, it's a little bit deteriorated, a little bit problematic there. I treated her the right way. We treat these patients, some anti-inflammatory medication, physical therapy, heating pads, whatever ice. She left 6 months later, she came back, the same problems, took another CT scan. Usually I don't do CBCT often on my patient at all, but this patient was interesting. 6 months later, look at the right joint, you see some changes in the cortical bone around in the right joint, and look how advanced the changes in the joint on the left side. Again, same treatment. Patient left. She's a businesswoman. She travels a lot. So 6 months, 8 months later, she came back with the same problem, limited opening, jaw pain. Took another CBCT. That's 18 months later. Look at the TM joints. This is the right side, and this is the left side. If you look at the frontal views, the bone is very fused. It's hardly, you can see there is space, joint space. And the same thing here, and where's my pointing? Very distracted joint. And the same, and after that, I sent her to the neurosurgeon for evaluation and treatment, and the patient disappeared. Now, this patient is 80 years old, came to me with history of lung cancer. Well, the history was severe pain on the left side, severe jaw pain. Palpation, taking the history, and part of the history, you're going to ask the patient about their past medical history. And he had the history of lung cancer years back and was cleared. So the impalpation, the severe pain, swollen on the left condyle area in front of the ear. We took panoramic X-ray, look at the lateral views. This is the right side, nice corticated condyle, and look at the destruction on the left condyle. We sent, and this is the frontal views. This is the right side. See how it's calculated. Excuse me, this dark image. But look about on the left condyle. A lot of radiolucency, bizarre radiolucency in the condyle. We did ask the patient to go for MRI, and this is the MRI results. So there is metastatic cancer to the left condyle. I'm not sure how much the patient made it after that. So this is, again, history, imaging targeted modality, and make her the right referral in the right time. Now, I see probably 50 plus young patients a year. When I suspect some kind of irregular findings in the CBCT, very weak cortical bone. I know I know the TM joint is a growth center, so it depends on the patient age. I don't really jump and diagnose the patient with rheumatoid arthritis. We take the history, we do the blood work if needed. If there is more pain and other body pains, we ask the patients or the parents that they are with the patients. So this is the right joint. See how fuzzy condyle. So this is really give us a hint that we should really further investigate the patient's symptoms. So we need to send the patient for further testing. Usually, as I said, if I have any positive indications of juvenile rheumatoid arthritis or juvenile idiopathic arthritis, I'll send the patient to pediatric rheumatologist. Again, degenerative arthritis, this is, you can see here, the eroded surface. I'm not sure really with my colleagues here, I do see probably 80%, 90% of my cases, the degenerative changes mostly on condyle. And probably the 10-20% I see it on eminence. I'm not sure really if what they see in their practices, but this is the average. And when the patients come with both sides of the TM joint are arthritic and eroded, that means probably there's more advanced arthritic changes in the TM joints. This is my personal observation. We jump a little bit to the MRI of the TM joint. These are some anatomy of the normal joints. I'm not gonna go over this. So this is a normal TM joint. This is the disc or meniscus. I know most of us call it disc. I like to call it meniscus, but that's easy for the patient to understand. And when the patient here open their mouth, you know the disc gets in the right position. So this is 11 o'clock position. Now it's about 1 or 12 o'clock position. This is normal joint. Now, if you can see here, this is the disc, the black area. It's in the front of the condyle. So it's displaced disc here. Now, when the patient opened their mouth, that's what, when you order MRI of the TM joint, specifically to detect disc location and disc functions, you can ask the radiologist or the center to do closed and open joints. When the patient opened their mouth, see the disc moved a little bit out to the normal position. So this is displaced disc with reduction. Now, this disc is here outside, and you see this white area here. This is fluid. This is effusion. So there is some inflammation in the joint as well. So this is the disc here. And when the patient opens their mouth, you see crumbling, the disc crumbled here. So this is displaced disc without reduction. So this is how you find, if you're not familiar with the MRI and it happened to have some MRI, you can really look at the disc, like black. It depends on what platform they are using, but this is when the patients open their mouth. So there are other signs of internal derangement with the reduction, without reduction during the examination. I'm talking here mostly or only about the imaging findings. Please don't depend on this for diagnosis only. Now we shift a little bit to section 3, which is really talking about neuropathic and idiopathic facial pain, which is visualizing the invisible. Neuropathic and idiopathic facial pain present a different challenge, as they often lack clear structural findings or imaging. Unlike endodontic or TMJ disorders, these conditions stem from nerve dysfunction or altered pain processing rather than visible anatomical change. So imaging, therefore, plays a supportive role, primarily to exclude any secondary cause of the pain, such as tumors, such as vascular compression or intracranial pathology. So we kind of here focus on the using of imaging while recognizing its limitations in evaluating these often invisible pain conditions. Trigeminal neuralgia, we know that's mostly is a neurovascular conflict, where there is some neurovascular conflict. The aim is to detect neurovascular compression at the trigeminal nerve roots entry zone. So the best assessed with high resolution is MRI of the posterior fossa. Standard MRI is, let me put it this way, not every MRI that can take MRI of the trigeminal nerve, they can, but they need really higher resolution. There is a protocol called Fiesta or CIS, CISS, which provide extreme contrast needed to visualize the nerve from the vascular, the blood vessels. The details is crucial when planning surgical approach. There's nerve decompression, or it is really good successful surgery lately. It's been for many years, and now it's very easy and very successful surgery. Neuropathic trauma and idiopathic facial pain have different imaging goals. Post-traumatic neuropathic pain aim to identify pathology like nerve injury. So using the CBCT, we use the MRI and CBCT if we looking for the nerve canals. So some bone fracture in the bone, some destruction of the nerve canal. So the CBCT not for the soft tissue, we know that, but some MRI of the brain and facial and neck will be recommended. So the idiopathic facial pain is a diagnosis of exclusion, using MRI to rule out tumor or demyelinating diseases like multiple sclerosis. So we should find the cause versus exclude the cause. This is a trigeminal neuralgia. We see the compression of the anterior inferior cerebral vein and the right trigeminal nerve. So this is the vein, and this is the vein. It took me a while to be able to read these MRIs. So it's very hard to read them. It should be read by a neuroradiologist. Again, this close-up, this is the anterior inferior cerebral artery over passing over the trigeminal nerve. Again, this is another one. We'll jump to the section 4, which is talking about headaches. There are too many considerations for headaches and how to identify red flags and autonomic triggers. Headaches disorders can present as facial pain and are often missed in dental evaluation. They may mimic odontogenic or TMJ pain, but are neurologic in nature. Sometimes tension headaches or cluster type headaches or migraines, patients complain about teeth, and it could be really sometimes dental migraine headaches. So we have to recognize the pattern and the red flags when these patients come, including autonomic symptoms, imaging, mainly to rule out any secondary causes, such tumor or some other blood vessel problems in the head. So we have to always, if the patient's migraine headaches is clear, then really you don't need this imaging. But when you suspect secondary cause, then you have to consider that. I'm not saying if you are not capable to treat headache patients, make referrals. The referral is very good. You establish good relationship with your other medical colleagues. So recognizing a red flag in headaches is critical, and it may be a signal for serious secondary cause. Warning signs include tender scalp onsets, pain, focal neurological deficits, fever, or new headaches after age 50. So these are some issues you have to look for them. So for emergency, start with the non-CBCT, contrast CT scan, and I usually always do that. I have no problems do as first line because sometimes you need to use the time, especially if the patient cannot see a neurologist for a while. So new headaches, severe headaches, patients over 50 ask for CT scan without contrast. If the patient has history of headaches and some new headaches, you have to request also CT scan. For stable cases, MRI is preferred to detect tumor, infection, or other pathologies. So you have to weigh which way you need to go. But usually for established patients, MRI will be good. For emergency cases, CT scan will be the best. So you have to match the urgency and imaging to the clinical presentation. Again, tie them together. Don't order unnecessary imaging for our patients. These two lines are just an error. Okay. So in primary headaches disorders, unnecessary imaging should be avoided. Typical migraines are clinical diagnosis, and routine imaging is not recommended, as I mentioned earlier. Or some exceptional cases, trigeminal autonomic cephalalgia, like cluster headaches, may require a brain MRI. So again, avoid imaging in typical cases. Use it selectively for atypical or high-risk problems. This is diffuse midline. This is glioma, patient with headaches. So I'm not expecting any of us to be looking for these without a referral, if really incidental findings, if you're looking for something. So again, make sure really you make a referral, the right referral to the patients. And sometimes these come as incidental findings for something else you're looking for. I have this master matrix. We did a while back, came up with the white papers for imaging, and this is almost the same. So for odontogenic pain, you can request 2D X-rays. CBCT or CT is secondary. For sinus ear pain, CT or CBCT, most likely, if you suspect, if no findings on CBCT, request CT. Soft tissue of the TM joint, MRI is standard. CBCT or CT is for TMJ bone problems, trigeminal neuralgia, specialized MRI, and for secondary headaches, CT scan and MRI. So these are the schedule you put in your mind what to do for something like this. So choosing imaging based on pathology and tissue balance details with radiation. Going the end of the presentation, again, to wrap up and take away with message takeaway, always start with teeth. As we know in our practices, 75% our patients are odontogenic, come with odontogenic sources of pain. TM joint, you have to rule out soft tissue versus hard tissue. CBCT, CT scan for hard tissue, MRI for soft tissue, articular disc, trigeminal neuralgia or neuralgia in general, Fiesta or CIS, MRIs, and for restraint and imaging for headaches based on the neurological findings, red flags, you decide what you want. As I mentioned earlier, this is really more toward to give you ideas. Dr. Gary Classer and I wrote a wonderful book. If you want to scan the QR, you can buy it from Amazon. If you are into institution, there is a special rate from the publishers. So that's really what I have here. Plus, I can share with you some of my hobbies, making food, chocolate. This is my creation. And thank you.
Whoa, thank you very much, Ghabi, and thanks for allowing us to show and to know also this wonderful hobby. Have to keep in mind to keep it in mind when coming to the US next time. Well, what else? Wonderful lecture, and I think it's been a very nice example. It was tough, okay, because you never know which kind of audience will be connected, no? So the risk is to be too complicated or too simple, and I think that as expected, you did a wonderful job to cut in the middle, no? Information really useful for everybody, both the beginners, which is in the spirit of our international association, but also for those who are a bit more experts. I think that you have been perfectly on time, so just in case we have the possibility exceptionally to remind everybody that the next webinar will be held by our Steve Bender on the fundamentals of temporomandibular disorder management on May 18 at 2 p.m. Central European time. Europe is also in the summer the time, so basically we are 6 hours in advance with respect to the US East Coast and 6 hours later than Perth in Australia, just to give you the two extremes. And that's why also we selected this time of the day for our presentations. Well, Ghabi, I don't know if you have to give us anything else to say.
I don't accept if anybody has any questions. I really don't know if there are any questions. I'll be more than happy to answer them. I don't know how the practice for orofacial pain in other countries. Definitely in the United States, orofacial pain is a specialty, and we can really do more things uh, while, like, from different perspectives, prescribing different medications, prescribing, ordering imaging. So if any question there, they can send me an email uh, to caspo511@gmail.com. It's a very simple email address. KASPO511@gmail.com. I know you can type it somewhere. I'll be more than happy to do that. Otherwise, if you have time, if there's a couple questions from the panelists, I'll be more than happy to answer. But I think overall was simple, straightforward. Some recommendations, some limitations, what you can, what you cannot do.
Yeah, that was fantastic. I took the freedom to answer one simple question about CBCT and MRI in the chat while you were talking. I think that when selecting the appropriate imaging approach, some of the decisions are unfortunately also based on the healthcare system, right?
That's correct.
For instance, in Europe, in some parts of Europe, we probably have paradoxically an easier access to MRI than in the US, where it's probably more easy to rely on CBCT. That's why there is focus on the bone tissues as well.
I'm not sure really in Europe. In US, yeah, there's some challenges with MRI because the insurance and the cost of the MRIs. There's always request for, we call it peer review. You have to justify why you need the MRI. So some insurance companies cover it, no issues, certain patients, certain contracts. Others, they request prior authorization from the insurance companies. So there's peer-to-peer review. So you talk to another physicians, mostly physicians. Most of the times they approve it. Very rarely they don't. So they need a reason why they. Yes, Gary.
Sorry, I was having a lot of trouble here going in and out of the meeting, but I did hear some of this. And I would just like to emphasize something that you said that I did hear because I think I was missing half the time with my internet connection. I think it's really to be a good, responsible expert in orofacial pain, at least at the level of a specialist. We really have to have, and you pointed this out, a good understanding of imaging, what to do it, and how to read them. And I will tell you examples. I can give you numerous examples of imaging that we've come back as with the written report as normal, where we find pathology that has been overlooked. The subtlety of a vascular contact or a mass effect where the brainstem is pushed to one side, which is just basically subtle. That is, sometimes attributed to head position in the machine, for example, which turns out to be a benign tumor pushing the brainstem and encroaching on the on the trigeminal nerve. So I think that we should have a greater understanding as specialists in how to interpret these films, not to be the expert, but to at least know when something's not right, to not be embarrassed to ask for a reread.
That's correct. Gary, I really second you.
Yeah, I absolutely agree, Gary, because my feeling is that nowadays, again, of course, I speak mainly for Europe, there is a tendency to bend science in favor of the healthcare system issues, no? You cannot be a specialist or you cannot diagnose everything without imaging, no? Also, as far as the temporomandibular joint, so talking about the basic issues are concerned. So thank you for pointing this out. If you don't mind, I'd like to involve our friend and board member Satish in the discussion, just to tell us how about the situation in India.
I'm not too sure exactly. I mean, you're looking at imaging, or you're talking about temperamental joint disorders and management.
No, I mean the topic of imaging, so the topic of today's lecture.
Okay, so as far as imaging is concerned, it's like what Dr. Ghabi just explained. Those are the imaging we are still using in India right now. And very well mentioned about the sinus and how we could also triage or refer patients in line up with the neurologist and others.
So you don't have problem sending the patients for request an MRI of the TM joint or of the brain because of suspected trigeminal neuralgia or displaced disc?
No, of course, no. If the diagnostics clinical findings are kind of relevant, you can surely refer patients as a dentist. If you have a neurologist or any other specialist in the team, it's always better to bring them online and do it along with them. If not, if it's an emergency, you can still refer.
Well, it makes sense. That's the same situation we have in Italy, and of course, it simplifies things a lot. Okay. And by the way, thank you very much, Satish, because you are involving a lot of persons in this adventure. There are messages saying we are here because of Satish. So
We're trying to do our best from here because I think the message is not spread fully. We are trying to spread the message and get more people involved into the webinar programs, at least for basic knowledge sharing platform. Not as an, I mean, it's not, I mean, for experts, it's okay for them. It's kind of revision or just to see what we're doing. But for beginners, it's a big eye opening. Even to just talk about the topic of MRI or imaging with the temporomandibulus joint and the other 3 webinars we had, it was surely an eye opener. That's what I'm hearing from my people here in India who are freshers into the field. So I think more and more programs will give them a lot of insights, at least an idea about the specialty in the first place. And I think that's the aim why we brought about these webinars.
great, thank you.
I just want to add one more thing, if you don't mind.
Yeah.
The issue here with you brought up about peer review. Very frequent.
Peer to peer.
Yeah, peer to peer. Basically, the problem that I have is that the people who I'm having my peer to peer appeal with know less than we do. And you have to educate the guy who's, it's like the non-expert reviewing the expert. And they don't know what we're looking, and you point things out, and it's, oh yeah, now I see it. And that's not what you want to hear from the guy who is denying the procedure. So it takes not only to educate ourselves, but to educate the insurance industry as well. And I'll be quiet.
Gary, you are absolutely right. That's why they approve it. There are some certain guidelines they have to follow, and they know because they are not the expert in this field, so they approve the images or the request for the MRI or something like this. But yeah, you're right. They are not. Sometimes you talk with nurse practitioner, has nothing to do with what we do and does not know anything.
So recently we had
my friend Gary Classer, Dr. Classer here.
Yeah, Gary's here, and I also see Zaha, our board member. So
Yes,
thank you very much for joining us.
she's always here.
Yeah.
Hi. Thank you so much for such an insightful lecture, really. And yes, people here in Jordan are very interested, and this field is just growing. We're trying to raise awareness a lot, and we always look up to the leaders and experts like you and our colleagues on the board. Regarding well, today there was a mix of time. My bad, because I don't know. It could be because of the summertime change. I announced it's 4 p.m. in Amman and it was 3. So I apologized. I just sent a quick note and many managed to, to come in and sign in. One question, if I have time, Dr. Kaspo, you mentioned that your protocol is not to not to take MRI or order MRI in disc displacement cases, which I understand. However, could you expand on that, on when and would you order it?
As I said, if clinically it's obvious internal derangement, the signs, the physical examination or the clinical examination, I don't. I do it only when the patient has more locking, more pain, a more limited opening, and I need to refer the patient to an oral surgeon for evaluation. This is really mostly where I request MRI of the TM joints. When my treatment protocol is not successful for some reasons, and that's why when I do, and I tell everybody like I do MRI of the brain more than I do with the TM joints.
Thank you.
Is fair?
Yes, thank you.
I don't know if Danielle has another way to, or some of our colleagues on the board.
No, Ghabi, I think that we can all agree on this perspective. Okay, there are situations that you can manage pretty easily without prescribing an MRI, and others, of course, I'm the one who personally perform arthrocentesis in most cases, so the population of patients that personally I see is biased, okay, because most of them arrive directly with an MRI, and this is also good on the one hand to study the correlation with the clinical issues, but on the other hand, probably it is not fully representative of the entire population of temporomandibular patients with easy situations to manage. So I will invite everybody to read the very nice paper in the 90s from Freibeck and in the Medical Imaging Journal concerning the effective prescription of TMJ imaging or imaging in general. When you get chance that your imaging prescription changes the treatment outcome, it's the time to prescribe it. That's how I see it.
I like to bring a couple of cases in my practice here, and both patients have very limited opening. For many, I tried everything from treatment, physical therapy, medications, and everything. They could not open their mouth more than 35 millimeters. So we sent them for MRI, and both patients, the discs were anatomically normal position. At that point, really, you have to look at beyond the disc. What's causing it? Is it muscle spasm? Is it anxiety? Is it somatization? So we have to look at the patient's evaluating, and after treatment, unsuccessful treatment, you have to look what caused the limited opening and what's the symptoms.
Okay.
Well, I guess. Thank you very much, everyone. And we have to get going. Our patients.
Yeah.
Nice seeing you all. If you need any questions, please send me an email. Thank you.
That was a wonderful presentation. Thank you so much.
You're welcome.
Thank you, Daniel.
Thank you, Guido, for
that. See you next month with Steve Bender. Thank you, Ghabi, Kaspo. Thank you, everybody, and thank you to our board members, Ghabi, of course, but also our president, Gary Hare, Satish Devarajan, Zaha Khalife, and Ovidio Sarakutu, who were connected with us today.
Have a good one, everyone. Take care.
Thank you.